Okay, welcome everyone to session 4, which is on models of care. So the presenters of this session will outline successful, innovative models of care that they've implemented in their practice to enhance hepatitis C testing and treatment. So our first session presenter is Dr. Jonathan Ho, who's a forensic medical practitioner and mental health drug and alcohol general practitioner at Wagga Wagga. They're also a forensic medical lead, violence, abuse and neglect service at Murrumbidgee Local Health District, and the visiting medical officer of Far West Local Health District, general practitioner liaison, mental health, drug and alcohol Murrumbidgee Primary Health Network. Keeping very busy, Mr. Jonathan. So I'll hand over to you. They'll be presenting on utilising a pharmacy model of care to manage hepatitis C.
Good afternoon, everyone. My name is Dr. Jonathan Ho. I just want to double check whether you can see my screen okay.
Looks great. Thank you, Jonathan.
So my presentation today is General Practice Pharmacy Model of Care for Hepatitis C. Thank you so much for the introduction, Bianca. And I'm just going to make an acknowledgement to country and to the elders past, present and future. I also want to make an acknowledgement for people who have lived experience of not only medical conditions that has affected their health, but all of the surrounding circumstances that may be trauma or other things that I'll talk about today, including health discrimination. Also want to give a shout out to ASHM, they've been wonderful, and also to our local services that I work with in my area in New South Wales, in the Murrumbidgee, Dr. Kim Collins, our sexual health physician, as well as the Murrumbidgee Sexual Health Service. Also want to acknowledge the New South Wales Mental Health Commission, which a lot of the principles of care is based upon, and of course our local collaborators, which is the local pharmacies in the Murrumbidgee. Bianca's already sort of introduced who I am, and I guess the impetus of what I was doing was in 2017, I was awarded GP Registrar of the Year for our district as well as for the Australian Capital Territory. And then in 2019, I received the New South Wales Mental Health Commissioner's Community Champion Award. And it sort of made me think a little bit about, well, what can I do for the community, particularly if I adopt a person-centered trauma-informed approach with people of the priority population group, whether they're LGBTI, whether they're Indigenous, whether they're people who've experienced violence, abuse, neglect, old people, young people, people who have been touched by the justice system. And so in view of that, I wanted to share my experience, which is how can general practitioners in pharmacies provide rapid change at minimal cost to tackle hepatitis C in the community. And the content of this webinar includes where the idea came from, what the need were, the scope, as in what I was doing and the limitations, the outcomes and learnings. And then after all, the speakers will be having some questions. So the idea, back in 2018, I was doing sort of a shadow term with our local sexual health physician, and one of the Gilead representatives, Amanda Girdlestone, said in one of her talks, and I remember verbatim, I heard her say, quote, "There are still a few percentages of patients that slip through the cracks, more difficult to treat patients, less motivated with other comorbidities." And this was the little kernel, the little seed that was planted in my head. And it didn't leave. And I was sort of thinking about some of the changes in our local region, such as we already had a hepatitis nurse in the Aboriginal Health Service that I was currently working at. And we actually got a lot of patients through that opportunity to be treated. However, due to service changes, she left the service and we no longer had anyone in the community providing sort of that model of care. We did, however, have the sexual health service, and they were, of course, treating hepatitis, but they were they had some limitations, service limitations. And then there was a big push back in 2017, 2018. A lot of education was being rolled out through our governing body for general practitioners, which is the Royal Australian College of GP, as well as the ACRM, to upskill general practitioners to deal with hepatitis C in the community. And I got some an idea of the needs in the community. I started getting quite a lot of direct contact from local pharmacies. Initially, they'll be calling me saying, hey, you know, we've got this person that might, you know, fit your skill set. You know, could you see them? And so initially, I would accept those referrals and I would move them to existing services that I was working at, namely GP practices. It didn't really fit, and I'll explain a little bit why later. So subsequently, we trialed it the reverse way, where I would actually travel to their on-site pharmacy and provide a collaborative assessment and review. And that actually worked. And currently, I'm on site 2 days a week at a pharmacy, including half-day Sunday clinics to help people who are either working Monday to Friday, or people who don't have transport, or people who are just afraid to go out and about in crowded, in crowded towns. So I guess looking at the scope now, my focus was on the priority population. This is a group of people that are more at risk of lots of conditions, particularly hepatitis C, but they have sort of special needs that I think require a very special approach. And we're talking about people who identify as Indigenous, LGBTIQ, IA+, people who have experience of mental health, drug and alcohol, people who are low socioeconomic, and my model is completely bulk billed, people who have recently been pregnant or are currently pregnant and they might have substance usage, older people, younger people, people who are non-English speaking background. Particularly where I'm working is regional, but we understand that rural and remote regional people are disadvantaged, and of course people who've experienced violence, abuse, neglect, and people who have been touched by the justice system. So the scope is also identifying and finding ways of tackling health discrimination. I define health discrimination as like how the World Health Organization would define it, as well as the Australian Institute of Health and Wellbeing. These are modifiable social and attitudinal factors that actually affect people's healthcare. We know that when there are attitudes that are biased, are often hidden by a clinician, these can be reflected on the patient, and they in turn have a negative effect on their ability to seek healthcare. Because of these modifiable factors, bias and attitude, it actually results in people not wanting or not being able to actually seek healthcare that they need. And this can be one of the factors to reduce people, like what Amanda Girdleston said, the more difficult to reach people from actually getting treatment where they need. So the other thing about scope is the limitation. So I want to provide some caveat. So this isn't a research study, nor is it a pilot program. Therefore, I'm not going to present any quantitative data today. The other thing is, even though this touches on hepatitis C, it's not specifically only for hepatitis C. It is a model of opportunistic care, which can be quite holistic and encompasses hepatitis C management and treatment. The other limitation is capacity. I've been, I guess, thinking about this model in 2019, trialing the model in 2020, and when coronavirus hit around April, May in Australia, that's when I started really rolling this out, and it's been 12 months, and looking back now, we're actually turning more people away than making bookings. So it's nice that I have the community support. just to give you an idea of a very busy slide, and please excuse this, but it gives you an idea of what type of patient I'm dealing with. So in this presentation, I have a real patient, a case formulation, and he basically came in with tiredness, and we subsequently found that he had iron deficiency, anemia, some bowel change, and then with investigations, he had untreated hepatitis C. And you can basically see through the slide, there were a lot of factors that was affecting his ability to actually get treatment early. I'm not going to touch too much on this because of time, and I'm sort of going to move on to my next slides. But you can see that it has to be a biopsychosocial approach, a trauma-informed approach, and a person-centered approach in order to actually win and build trust for the patient to accept treatment and actually reduce his chronic conditions and improve his outcomes. So the possibilities, is it actually possible to provide relatively low cost care to the patient? And yes, it is. All of my patients that I see is completely bulk billed. There is some caveats to that. The patient still needs to, get a taxi or pay a bus fare. Patients still need to, clock off, say if they needed to come to an appointment when during business hours, and patients still need to, pay for medications. Can we provide responsive care to the patient? Absolutely. This model of care is designed to be flexible. However, there are some caveats like what I've said. As we increase demand for the service, capacity often is maxed out. Can we provide holistic, biopsychosocial, person-centered and trauma-informed care? Definitely we can, but that needs to be balanced, of course, by negotiation with patients. Often these patients are very, once they trust you, they will be very open to tell you exactly how they feel, and it can provide opportunities of conflict. But because of conflict, it also provides opportunity to strengthen relationship as well. So sort of managing that person-centered relationship, I think, is really important. Can it meet patient goals and treatment-orientated goals? Absolutely, because if we start off understanding the person's goals by active listening and providing consent and informed consent to let them know exactly who you are and what you do, we can come to a consensus in terms of what we're doing together. Can we provide a treatment approach within a collaborative care model? Absolutely. I work right in the dead center of town. I don't work alone. I work in a team of people, whether it's pharmacies, specialists, whether it's the hospital, whether it's non-government organizations, government organizations, and it's about communication. So the learnings. So with that case presentation, that busy slide that I gave you, through a few consultations, we came to this point where he said, I had a car for years. You know what? I never lifted the boot. Well, one day, this was about 3 years I bought the car. I opened up the boot. Oh, fuck. Rusted hole right on the tow bar, and I've been towing things. And I thought, oh, fuck. And worried about that all the time. You know what I mean? And that was his understanding, that his fear of wanting to get treatment, his fear that if he saw a doctor, things will get worse. It now hit that there are other ways of actually dealing with his anxiety. And one of those ways is actually treatment. Another patient said, I feel really anxious, just walking around in circles, more or less. And this is a highlight of, I guess, health discrimination, that because of what's happened, he didn't know where to go. And so this was an opportunity for us to restart. The other learnings that I had was, like I said, consent should be the central pillar of care. Most of the time when I see people in the pharmacy, I ask them, do you know who I am? Do you know what I do? 90% of the people will say no, even though I'm wearing a pink stethoscope and I introduce myself as Dr. Jonathan Ho, because they're not familiar with seeing a doctor in the pharmacy. And I think it's really important to let them know who you are, why you're here. Can I get your permission to talk to you? What are your goals? Can we, work on stuff together? I think a trauma-informed approach is really important. And I guess that's tied in with consent. And I think it's really important to improve agency and facilitating the patients to actually have control over their care, whether it's the information that they provide you, whether it's about consent. whether it's about confidentiality and privacy. Having compassion, having compassion and genuine, authentic listening really helps build at the speed of trust, and acknowledging when they do share their story, the power and validity of their lived experience, and affirming the dignity of that story. Not just focusing on the end goal, say treating hepatitis, but holistic care, which they really love. And showing the power of collaborative care, that a whole team is wanting to serve you, and sort of what we wanted to do, explaining things in plain English within a dialogue, not didactic, so that they feel like it is about them. And of course, reducing barriers to care, whether that's financial or otherwise. So I wanted to leave that there because of time. We'll have questions at the end of all of our presenters, but I wanted to thank you so much for listening to, I guess, what I've been doing in the community. And if you did need to contact me, I've got some details at the end of my slide. Thank you so much for this opportunity.
Thank you very much, Jonathan, for your presentation. We've also been able to extend the session by 10 minutes, so that's okay. So we've got some more time for Q&A at the end of the session. Just as a reminder, as Jonathan has alluded to, if you enter in your questions in the live Q&A, we'll talk about those at the end of the session. So we'll move on to our next presentation, which is by Dr. Brian Conway, who's the Medical Director of Vancouver Infectious Disease Centre and Adjunct Professor of Faculty of Health Sciences at Simon Fraser University. Brian will be presenting on their model of care in Canada and further adapting the service due to the COVID-19 pandemic. Thank you, Brian. Oop, you're just on mute at the moment, Brian.
No, I thought I had this all figured out. Let me start over. I shared well. Anyway, let me start again. It is a pleasure to be with you on this late fall Saturday afternoon to discuss some of the models of care that we have developed here on the west coast of Canada, how the COVID pandemic upset our models of care, and I think led us to improve them so that we can stay on course to eliminate hepatitis C as we are meant to do over the next decade. And these are my disclosures. To remind ourselves, the World Health Organization has set for us a goal of eliminating hepatitis C as a public health concern and viral hepatitis in general within the next decade. And to do so, we would reduce new viral hepatitis infections by 90%. And if we're successful, we will have a significant impact on the morbidity that's associated with viral hepatitis, reducing mortality in particular by 65% or more. Homi Razavi and the Polaris Institute have really done a lot of work to determine which countries, by the structures and programs they put in place, is on track to meet these very lofty but important goals. So in 2017, when this was first done, a few countries, including Australia, were on track to meet this goal. Over the next couple of years, a few other countries, including Canada, have come online and were, prior to the COVID pandemic, on target to meet this particular goal. Now, if we extend it a little, maybe to 2050, 2 decades, 7 other countries, but a majority of countries here listed alphabetically, and we're talking developed countries, not Egypt, not Georgia, countries here alphabetically from Bahrain to the United States are not at all on target to meet this goal. So those of us that are on target, it's important that we try to maintain our momentum. So what's happened in Canada? We have around about 250,000 people that are infected, and calculations were made back in 2016 that we needed to treat between 10 and 15,000 individuals on an ongoing basis over 14 or 15 years to meet this goal. As DAAs got rolled out, we exceeded this threshold in 2017, did a great job in 2018, fell back a bit in 2019 as the warehouse of easily treatable patients was sort of winding down, and we needed to launch programs to find those that are undiagnosed and engage them in treatment. And as COVID hit, we sort of started to fall below the threshold that we needed to maintain. And the decrease from peak down to what we observed in 2020 was 40% decrease in treatment starts. And the question that we need to answer is, are we still on track? And if not, what do we do to get back on track? So why did this happen? So I will speak of the inner city and vulnerable populations in Canada, and in particular my own Vancouver city and its downtown east side depicted here. Population about 18,500, 80% active drug users, 2/3 infected with hepatitis C. And this is a disengaged, disenfranchised population. It is characterized by financial insecurity, so poverty rates that are at least double that observed in the rest of the city, often having housing instability, not being linked to the healthcare system at all, and suffering from sort of systematic separation from mainstream society in general and from the ability to access HCV treatment in particular. So several years ago, we reasoned that the first goal of engaging this population in care to receive hepatitis treatment was engagement itself. And we launched a novel program called the Community Pop-Up Clinic. And these locations that are shown on this slide are in or near the downtown east side. And what they had in common is that there were places where residents came to get services, be it emergency housing, emergency food, to take a shower, use a washroom, do their laundry, and otherwise congregate. And we reasoned that if we met them where they were and set up the right structure, that we would be able to engage them in care. So a typical CPC looks something like this. Individuals present, they complete a questionnaire after having provided consent so we know who we're dealing with and can better target our programs to meet all of the diverse population of the neighborhood, including the 15% that are of Aboriginal, self-declared Aboriginal race. Some already know they have hepatitis C, and we can confirm that by contacting the provincial laboratory. And once this is confirmed, we can go through a process of engaging them in care very rapidly and give them an appointment at our center, which is not terribly far from the downtown east side. And I should say that the CPC is staffed by 2 nurses, a doctor, and 3 support staff. We'll see 30 individuals in a half-day period, just to give you an idea of what we do, and this is done on a weekly basis. Those who do not know their status do point-of-care antibody testing. If they're negative, that's the end of it unless they want to see us again, and everyone gets a $10 gift card. If they're positive, they go through the process that I just described. So we think that this is a tool of engagement. It isn't about hepatitis C. So the goal of engagement is a model that we've called the 4-legged chair, where we want to meet medical needs, social needs, psychological needs, and addiction-related needs. And in so doing, we can frame hepatitis C treatment with an overall plan of care, and hepatitis C treatment makes sense. This is operationalized by 3 pillars, where the goal is an initial engagement. It is multidisciplinary, as I've just described, and it is durable, so that once an individual is engaged, we continue to engage them in a dynamic way to try and meet all of their needs going forward. So to summarize the 14 months that preceded March 13th, Friday the 13th, when our COVID shutdown occurred here in Canada, is we started on treatment 10 to 12 per month, 93% cure rate, and very small number of individuals that are uncured. And of those that are uncured that we could re-engage in care, 2 of the 5 were cured subsequently with another course of treatment. So this is a highly successful program. It's done in the neighborhood. Once we find someone, we have them, and we rarely lose them to follow-up, and generate success rates for hepatitis C treatment that are very similar to those in the published literature and in clinical trials of inner city individuals. So once COVID hit, you will see by these 2 illustrations, first as a social commentary, that personal and social distancing on the downtown east side was very difficult, as it was in most inner cities. But our CPCs were shut down because the centers were shut down. Addiction care was delivered by telehealth, which was not necessarily appropriate for this population. And all other ancillary services in the community were suspended for several months, produced a big spike in opioid-related mortality, and deprived us of our ability to find and engage people in care. So when we restarted our program, we decided that instead of going to community centers, we would go to large buildings, single-room occupancy apartment buildings where people lived. So this was, instead of going where they used to go, we go where they have to go right now. And you can see that our CPCs are now masked, personally distanced, and appropriate to all workplace recommendations for safety in the COVID era. We provided COVID-related education to our individuals as value added, understanding what they needed. COVID antibody tests, which would be a talk for another day, as to who had developed COVID in the past and to map its progress through this particular community. And we send our staff back a couple of days later to follow up on individuals rather than obliging them to come to our center. This is staffed by nurses, and doctors' consultations are available by telehealth. So the new CPC is we coordinate them with our sites. We meet patients there who have missed their appointments with us a couple of days later. We do blood work on site. We bring our FibroScan if needed. We do virtual consultations with MDs, and we either follow up at our center or we can do the entire treatment on site as the system has become more efficient in the past few months. So these are the treatment starts. So you see, we took a big dive in March, April, May as we closed down. We did a bit better in June and July for reasons I don't understand. In August, we were back down to the April and May numbers. Better again in September and October as we relaunched. And what we've seen in the last few months is we've doubled our ability to treat, because this system is something we probably should have been doing before, going to the single room occupancy apartment buildings, the SROs, and we're able to treat twice as many as we did before and still provide multidisciplinary care. So our treatment starts went down to 80 or so over the last 3 quarters of 2020. They've gone back up to 33 starts, 10 or 11 starts, of which 19 were in March. And obviously, cure rates are not available on the most recent cohort, although 90% seem to have been cured of those we know. Now, during the COVID era, we were still curing people, just fewer of them. So now we've been able to ramp up with this new sort of model of care. So inner city populations need a specific approach, I think. It's not ever about hepatitis C, it's about hepatitis C in context. And the way we frame it, it's about engagement, multidisciplinarity, and durability. Once COVID hit, it affected the inner city in a disproportionate, unfair, and very distressing manner. Hepatitis C treatment programs were virtually shut down. But even in the era of COVID and in the new normal that will follow, we feel that it's possible to reestablish these programs meeting the very same objectives and actually potentially make them better. And we've clearly shown that we're able to resume HCV treatment starts right now. And the next goal for a program like ours is it's an ideal infrastructure to deliver COVID-19 immunizations that will allow this group to be part of the new normal as other parts of society have become. So hopefully this is useful. These kinds of models are easily adaptable to many kinds of environments, and I look forward to your questions after the next presentation. Thank you very much.
Thank you very much for your presentation, Brian. That was fantastic. We're going to move on to our final presentation for the session, which is by Dr. Albert Imp, who's a Senior Associate Lead General Practitioner for the Hepatitis C and Allergy Clinic at Springs Medical. So Albert will be presenting on the abstract, having a dedicated trained GP to manage and liaise with specialists improves hepatitis C treatment uptake in a localized region. Thank you.
Thank you, Bianca, for your introduction, and it's an honor to come and present what we did locally in Daylesford. Our area is essentially an LGBTI-friendly area, and our population ranges from 6,000 and swells to about 20,000 during the post-Sydney Gay Mardi Gras period, when all the Victorians come back down and party on in our local township. We also have a couple of local prisons in the region, and post release from prison, we actually get transients who stay in the region for a few months before they move on to their final residence. And we have a number of opportunities to reach this untapped population to try to treat their undiagnosed and undertreated hepatitis C. So before I arrived at the clinic, hepatitis C was really not a coordinated effort in the local clinic. Every doctor had a specialty that they liked. We had someone who was very interested in HIV, someone who was very interested in opioid replacement therapy. But this hepatitis C portfolio was just left a little bit floundering. And at the time in 2016, the DAA's direct acting antivirals hadn't come into play yet. And as you can see from the mapping project, the region of Creswick, Delsit, and DeLand had a reasonable comparable rate of prevalence in the local area, but the uptake of treatment is at the 35% mark, 34.8% mark. So doctors at the clinic were fairly undertrained and saw it as an area that needed too much expertise and time. And also, as some of the other speakers in the other forums have talked about, an under-remunerated type of activities as well. Because of that, we actually on-referred a lot of the patients to the local base hospital, which is 40 minutes away from our township. And that was the norm. The remote consultation for initiation treatment had just started to come into play, and FibroScan was, we had to refer either to another township, which was about an hour away, or back down to Melbourne, which was an hour and 15 minutes away. So they said, Albert, if you're coming to the clinic, you have to take on hepatitis C. So they were able to support me to go and undertake the ASHM course to get upskilled and so forth. I took the opportunity to use that skill and knowledge that I gained in the ASHM course to actually continually, annually update and train the rest of the clinic on new developments in hepatitis C treatments. I then established direct contact with local base hospital specialists, including hepatologists and infectious disease people, and continued to have phone and SMS discussion on how to manage complex and difficult cases. So much so that we were able to facilitate early endoscopy when needed, manage difficult drug and medication interactions. And at the same time, we were able to apply for and successfully get a portable FibroScan funding for the region. And as a result of the activity, the base hospital was happy to share the FibroScan for half a day every 3 months at our local GP clinic to actually do the FibroScanning. This was a huge deal because, as I mentioned, the FibroScan opportunity was an hour away into another base hospital, or an hour and 15 minutes away to the metropolitan Melbourne. Everyone's been talking about the cost to the patient, taking time off and travel costs and so forth. This allowed an aggregation of the cohort of hepatitis patients to actually come for the FibroScan locally at minimal cost to them, and not have too much interruption in their day in terms of if they were gainfully employed. As I mentioned also, we had another GP who was really interested in opioid replacement therapy, and we were able to co-opt them into a multidisciplinary team type of management for the hepatitis C patients. And that sort of reduced the amount of people who were lost to follow-up as well, because they were co-managed locally as well. And as confidence developed by the local base hospital specialists, our patients that were referred to their waiting list was returned to the clinic to actually be treated by us at the clinic, rather than wait to the outpatient for specialist treatment. And Ballarat Health Service gastroenterologists and infectious disease departments have been very good in actually telling the patients to go back and see their own GP about this. As a result of the annual training, the GPs in and around the areas have also been able to know that there's this resource that I can be contacted quite easily to discuss the cases. And often I would help them in terms of managing the initial level of complexity. And if we didn't need the specialist, I was able to facilitate that service at a faster rate than waiting for the base hospital outpatient services. And as a result of that, as you can see, our uptakes of treatment rates have risen from 34% to 66% plus. You know, our prevalence has gone down to about 0.7 in the region. That's generally my talk, and I'm going to open it up for the Q&A session.
Excellent. Thank you so much, Albert, and all the other presenters from the session. So I'll ask everyone to enter your questions into the live Q&A, and I'll ask them of the panelists. I suppose I don't have there's no questions in there at the moment, but I have a question for you all. So I suppose, you know, you've obviously adapted your services to improve your model of care, but how easy was it to get management buy-in to do this in your services?
Hi, Bianca. It's Dr. Jonathan Ho here from Wagga Wagga. I guess my model is a little bit unique in the sense that there was sort of no external organisation that was sort of funding or sort of providing additional support, but it really was sort of set up within the community. I think it was really important to build trust in the community so that you know, this model could be sort of effective and trustworthy.
Hi, it's Albert from Daylesford. So I think, as I mentioned in my talk, this was really a portfolio of care that was pretty important, but somewhat neglected when I arrived at the clinic. And really, it was left to our own devices to try to grow the service and make it more streamlined and efficient. So it was kind of difficult, but we've seen the data, and I think there is much more support from the management as a result of that. We've made the clinic a lot more visible to patients who walk through the door, through posters. The word of mouth has got out through the community grapevine and Facebook and so forth about this as a service and a friendly service for people in this transient and truant type of patient population as well. So we've really relied on the patient's word of mouth to actually grow the service and demonstrate to management that this is something worthwhile and investing their time and effort into.
Well, I think there's two models that one could think of when you're developing systems of care such as have been described. They can be part of existing structures where you have to convince management to sort of change its views or to expand or accept what you're doing. Or you can be things like what is happening more and more here, including our institute, is that you're a freestanding entity that develops its own clinical services and defines its own mandate. And where success comes is that you develop a lot of partnerships with other community groups that accept you. So the most recent initiative that I was describing, where we go to the single room occupancy sort of dwellings to do our work, is really a collaboration between our entity and a large group called Atira Housing that runs 30 of these houses that take care of 2,500 individuals. So it was really establishing that partnership and finding common purpose. And I think that's sort of another approach. There's a big institution approach that can work, but also smaller, nimble institutes such as ours joining up with other institutes, finding common purpose and generating success in that way.
Excellent. Thank you all. We've got a couple of questions that have popped into the Q&A, so I'll address them to you all at the moment. So firstly, we've got one from Joss to Brian, actually. Fantastic presentation. What does your post-first visit engagement follow-up look like? He's run away.
No, I want you to see this. Can you see that?
Oh, the Combi Clinic.
Yes. Just so you know, I got this from the Combi Clinic. So we are. It was given to me by one of the Combi Clinic nurses when she came to visit us in Vancouver. Sorry. See how casual this is. I run away. I have it here. I had it close. So what was the question again? I was too busy getting the medal.
What does your post-first visit engagement follow-up look like?
So basically, we've defined with the individual what their needs are. A lot of times it's a social need, like they need a government form filled out, they're disengaged from addiction care, they've requested blood work. It's very important that that first post-engagement visit occurs in a way that is meaningful to that individual. It's their need, not mine. I may want them to go on hepatitis C treatment quickly. They may have advanced fibrosis. I may identify another need, but that first visit is really making sure that they get the idea that our services are going to be valuable to them, and then we build on that. But it really is making an inventory of their needs first, and then at some point sooner rather than later, hopefully getting back to Hep C.
Thanks, Brian. So we've got a couple of questions that come through from NADA. So our first question is for Albert. So thanks, Albert. Just wondering how you feel about FibroScan as a carrot. Do you think it's improved patient buy-in or help understanding of hepatitis C?
I think it's a huge incentive for the patients because they have clarity about even if they have a higher degree of fibrosis and cirrhosis, that we have the specialists backing us up on how to manage the difficult cases as well. So the FibroScan, if traveling to get the FibroScan done in another local township is hugely difficult because there is no direct line of transport, and a lot of these patients don't have their own transport and rely on other people to go to. So it actually has made a one-stop shop for these patients to actually come to our clinic. It doesn't delay our commencement of treatment because we've got the ARPRI score to guide us to initiate treatment anyway, but it does allow them to understand and follow up onto the future management of their hepatitis complications as well.
Thanks, Albert. A question for Jonathan from NADA. So thanks, Jonathan. Great concept of being in a pharmacy. Did you have your own provider number for the sites, and was there some non-Hep C patient engagement as well?
Hi, Nada. Thanks very much for this question. Yes, I did have my own provider number for this site so that I could provide bulk billing care to the patients. Was there any other things that we did? Well, the whole model is all about sort of holistic care. A lot of the people sort of come in for lots of different reasons. Most of them would be opiate treatment. And that's why they would sort of build a relationship with a pharmacist. Other things include chronic pain, and a bulk of the majority of the patients would identify with experiencing mental health, substance issues, as well as trauma, including violence, abuse, neglect. Quite a large population of these people, because of their trauma history or mental health, drug and alcohol, would also have had dealings with the justice system.
Thanks, Jonathan. So I've got a final question here to Brian from NADA as well. So thanks, Brian. Also love the concept of community-based care of the person and Hep C being just part of that. Has opioid mortality changed since you've reinvigorated the model?
I was muted. Absolutely, yes. Our opioid mortality is going down significantly in the residences with which we interact as we engage care and restore the previous models of prescription of opiate agonist therapy, and start to provide more in terms of a variety, I would say, of opiate agonist therapy, something that's called safe drug supply that reduces reliance on street fentanyl. So I think this is another, benefit of the types of approaches that that are based in the community.
Thanks, Brian. So we've got a question for the whole panel from JP. So a personal question to the panel, if I may. Apart from improving mortality and morbidity and treating marginalized populations, what else drives your practice?
Hi, thanks so much for that question, JP. It's Dr. Jonathan here. What drives my practice is the passion to help people take control of their health and to self-manage their lives. And by, I guess, modeling that from a clinician and giving them permission to make choices in their healthcare, I'm hoping that will create a drive, a movement, and hence a demand for change in how the wider community responds appropriately to their autonomy.
Any comments, Brian or Albert?
This walking in these neighborhoods, the level of social inequality that comes to that you see. I mean, I was in the media in August when someone videoed a gentleman relieving himself on the back of a building and then launched epithets at him. And I commented, "What do you expect? You've closed all the indoor washrooms to which he had access. So could we please?" So I think it's really that level of interaction with the community that recognizes the need to improve their daily lives and to contribute to that in whatever way we can. I'm not going to fix everything quickly, but I think that is a motivator. It's a motivator of the 15 other people I have the privilege of working with here at VIDC.
Hi, Albert here. So I'll add to that what drives our model. And that's been said by a few of the other sessions as well, the stigma and the rare fact that we've got something that we can actually cure at a very high rate. And that is something that the public, the patients, and even our colleagues have a fear factor of that we need to try to overcome. And this is something that we can do by 2030 if we really engage as many practitioners, inform as many people, and provide the service at a easier access type of scenario. So that's what really drove me to improve the model at my clinics.
Excellent. Thank you so much all. So that was the final question for the session. So I think we'll wrap up there. Big thank you, of course, to Albert, Jonathan, and Brian for sharing your practice and your model of care. It's been really valuable. So everyone, we have a quick 10-minute break, or sorry, actually 15-minute break until the next session, which is Advanced Management of Hepatitis C. That's starting at 2 p.m. Australian Eastern Standard Time. Thank you.